actually in the UK rather than at home taking action, but I was a nurse who participated in the 50-day strike, and perhaps I won't touch on that given that you have. But I guess to talk a little bit about what nurses and midwives in Victoria have been doing, particularly this century. It's extraordinary, isn't it? With no disrespect to you or I, because we did things in the last century. But I guess importantly, in much of the 1990s, my state of Victoria, so Victoria's that very little one right down the bottom, with quite an intense population, very heavily based in metropolitan Melbourne, but also throughout regional Victoria population as well. And we had almost 9 years of a Conservative government in Victoria, and during that 9 years we saw all of the things that we expect to see from Conservative governments, particularly in relation to public health. So slashing of budgets, and what that meant was that thousands of nurses took redundancy packages. We had over 400 beds that were closed on any given day in our public health system. We had about 1,300 vacancies, EFT, vacant, and much of our permanent nursing workforce had decreased from around 65 to 35%. And so, and lots of conditions lost as well in as far as length of shift and accrued days off, which is a special benefit or a special condition that nurses and midwives have across in Australia, but particularly in Victoria. And so we were really faced with 20,000 nurses that we know were registered but refused to work in the public health system, and really the public health system was sort of down on its knees. In 1999 there was a state election, and we had lobbied and worked hard to get the opposition, the then opposition, to commit to improving the public health system, because it had been, they had been so vocal in opposition, and in 1999 they got elected to government. So that fell at the same time as in 2000, when we were starting up our new enterprise agreement. And an enterprise agreement in Victoria is an agreement that's signed off between the union, which is ourselves, just the one union, the Australian Nursing Federation as it was then, the state government, and also then representatives of the hospitals, called the Victorian Hospitals Industrial Association, who the hospitals belong to, and that's their industrial representative. And we argued, we tried to negotiate an outcome, but it wasn't, negotiations weren't progressing, and we had in our industrial relations system an opportunity where if both parties agreed, you could go to this, what was then called our Australian Industrial Relations Commission, and a commissioner would listen to both arguments and then make a decision. And it was through that decision in 2000, when we hadn't been able to reach an agreement with the government, that we argued our case in front of the Commission. The employers argued their case in front of the Commission, and the Commissioner, Commissioner Wayne Blair, awarded nurse-patient ratios in Victoria. So we got them through our industrial relations system. They weren't given to Victorian nurses by any means, and nurses, instead of going on strike in Victoria, as we had done in 1986, we utilised for the first time a closing of beds. So what we did was we closed 1 in 4 beds in the health system, in the public health system on each ward, and we also closed 1 in 4 emergency department cubicles as well. And what we did then was also we kept an additional bed closed, so that if there was an emergency admission that needed to go to the ward, then we could make sure there was actually that bed was there, which the hospitals actually quite liked privately, because, and particularly the doctors and nurses down in the emergency department, because it meant that there was a bed up on a ward rather than having to keep patients in emergency departments for 24 and 48 hours. So it's through bed closures rather than going out on strike that nurses have been able to put pressure on the government. It certainly attracts an extraordinary amount of media attention. And in addition, it's something that all nurses can participate in. There is only some exempt areas. So for example, delivery suites and postnatal, we don't close beds. Paediatrics, we don't close beds. Oncology, dialysis, some of those specialist areas. But theatres, we closed theatre sessions, and the doctors and the surgeons and the nurses work together in relation to which theatre sessions will be closed, which patients won't go on the list that particular day. So we have been closing beds now in our enterprise agreements for 2000, for 2004, 2007, and again in 2011-12 has been the way that we have been able to put pressure on the government to reach an agreement around keeping our ratios. Since we got ratios in 2000, we've had to fight to keep them in 2001, again in 2004, and 2007 and 11. So we haven't had a government that hasn't tried, of either political persuasion, that hasn't tried to take those ratios away, but they are absolutely critical. And what we saw as a result of introducing ratios, there was also a range of other benefits that were introduced at the same time back in 2000. So we had a state government that in opposition had been complaining about and recognising how terrible the public health system was. And so we used this opportunity in front of that Industrial Relations Commission to get a suite of other conditions that we believed would encourage nurses to return to work in the public health system. And things like, for example, nurses got professional development leave, they got paid study leave. We had got rid of short shifts and limited them to having only one shift in the morning, one in the afternoon. We had a really critical recognition of nurses got an additional 3.5% increase in that 2000 for staying and working in the system during all those terrible years. And importantly, we also had a ban on agency nurses. This was a claim of the Federation, who was the union that obviously represents agency nurses as well. But there was a directive from the state government that agency nurses could only be utilised for unplanned vacancies such as sick leave. And from that we saw some 1,400 nurses return to work in the public health system, many of them on a flexible nurse bank, but stopped the hospitals wasting money on commissions to agencies and enabled hospitals to actually put the money into nurses providing direct care. And that was very, very critical for the success of finding the additional in part EFT to come back into the system, because when we got our ratios in, there were just hundreds and hundreds of EFT vacancies that we had to fill. There's no point having ratios if you actually can't fill them, so we had to come up with strategies and work with the government and the employers about how we could do that. We also got funding from the government in order to run refresher and re-entry programs. So this is for nurses and midwives who actually given up their registration and left. There was opportunities for them to come back and be supported financially to do that, rather than having to find thousands and thousands of dollars themselves. And then also nurses who may have been out only for a short period of time and just needed what we call a refresher program. And so money was given by the government to the hospitals to fund those programs. So we also got a large number of nurses and midwives back in the system working for the first time, some of them for many years. So that was really critical. It was 2004, as I said, we had to fight again to keep our ratios. The government wanted to replace the ratios with the patient dependency system, and we've been very against patient dependency systems. You know, they are very effective at telling you what you needed to have on your shift, the shift before, but did nothing in relation to giving nurses any sort of certainty or satisfaction, not to mention the number of patients that they'd have to be looking after. In 2007, once again we fought, but during these times, 2007, we started to get improvement in some of our ratio areas, for example, midwifery, postnatal units, our emergency departments. And then in 2011, 2012, I think we've had the longest campaign that the Federation's ever been faced with. It was a 9-month campaign. It was under a different industrial relations system, a new act that the federal Labor government had put in when they were in power. And what we did was we closed beds for a period of time, and then we were before the industrial umpire around the closure of those beds. The government continued to say, and the employers, that we were causing harm to the community by people being denied access to a bed or denied access to surgery. And what we fortunately found was, or the Age newspaper fortunately found, one of our newspapers, and someone had linked a document to them from the government, and it was the government's strategy in relation to our enterprise agreement. And the government knew that if it could force us into what's called an arbitration, where that we wouldn't, because of the way our laws are in Victoria, that we wouldn't be able to have our nurse-patient ratios arbitrated. So that was their strategy. And before we went to the Fair Work Commission around that issue, the front page of this newspaper had the government strategy all on it, and the government were exposed by the newspaper. And the Fair Work Commission decided not to we didn't have to stop our action, but we had to suspend it. So we were taking protected action. We then changed our tactic, and we did community rallies all around Victoria, and around about 33 community rallies in 16 days, and thousands of sausages and all sorts of things around the state. But really important to highlight the patient safety concern that our members, were so desperate to get that message across, and so they were very successful. And then we went back into negotiations. Negotiations were really still futile, and one of the things that we embarked on was nurses putting forward their resignation and giving us the opportunity and trusting us to make sure that we wouldn't hand that resignation in unless we couldn't protect our nurse-patient ratios. And we received thousands of those resignations of nurses prepared not to nurse in the system, particularly if they were going to be replaced, which was the government strategy, to substitute qualified nurses with health assistants in nursing. And in addition to that, what we also did was, for the first time, we actually started doing walkouts of hospitals. So not for the full shift and every shift, like the 50 days of the strike, but twice a day for a 2-hour period. So from 8 till 10 in the morning, and then in the afternoon from 4 to 6. And this was very successful. It gave us a great profile. It was about 18 hospitals that we started. We were starting with a small group of hospitals, and then we're going to expand it if we needed to. And we had nurses visibly present outside of hospitals, which Catherine would remember during the strike, the 50 days. So on very big major roads, big streets, it was nurses from other hospitals going and walking out with them and standing and supporting them as well. It did mean that they could then go back, because all of the nurses were being docked pay for the time that they were spending walking out. So it meant that we could share the load of people that were having their pay docked, so that the burden wasn't too much for everybody. And of course we also had what we started up for the 2007 dispute, was a welfare fund where nurses got docked their pay for taking action then as well. So all of those things we found, I guess, have been a new way of taking action, a new way of getting public support, getting the public involved, but most importantly, putting pressure on the government to come back to the negotiating table and negotiate an outcome. Both of the last enterprise agreements that we've done in 2011 and 2012, we faced federal court proceedings. 2007, the federal court judge, the case was held over as we were having our final meeting after we'd reached an agreement. But in 2011-2012, with our walkouts, the government took us to the federal court, and nurses who participated in that, including of course us union officials, were facing fines every day of those walkouts of $34,000, which is the equivalent of £16,000 a day. And so that court case was quite quite an extraordinary thing and very brave for nurses and the Federation to continue to embark on that despite the federal court injunction saying that we had to stop doing it. Nurses kept on going at great expense and great threat to themselves. But ultimately we were able to, I think, once the government saw that the nurses weren't going to stop, irrespective of the threats and the fines that might be coming from the federal court, it gave them more of an impetus to actually sit down and negotiate an outcome. And so we were able to save the substitution of nurses and midwives in the state by health assistants, which was absolutely sort of the cornerstone of our campaign, and certainly the cornerstone of what the government wanted to do. Listening to some of the things that you say about the NHS and the privatisation and the running down of the system and costs rather than community and patients are all the same, irrespective of how many thousands of miles Australian nurses might be from you. The issues, I think, with Conservative governments are all the same, wanting to have a cheaper public health system and ultimately one that they can prepare and run down and sell off to the private sector. And of course, I guess as nurses, we do know that the people that lose out of that and access is really the population, and you create, I guess, a community that don't get access to good health care because they haven't got private insurance. You end up with a two-tiered system, one for the rich and one for the poor, and that's something I think that nurses, no matter where they are around the world, have to stand and fight to stop that from happening. I think critically, picking up on one of the things that Catherine said also is, when I look at the standards, the nursing standards by our registering authority, the Nursing Midwifery Board of Australia, one of those standards is about patient advocacy. And so it's not just please stand up and be advocate for your patients. It's actually a requirement. When you become a nurse, that's what you take on as well. It's not just the bedside care, but being a patient advocate and advocating for the best health system and a better health system, and continuing to improve the health system is something that we love to do. So I'm very privileged to speak with you here today and to meet you, and really want to encourage you to do whatever it is that you can support, whether it's Catherine and the National Health Action Party, whether it be the unions, whatever other unions that are, getting everybody on board to make sure that you've got, great nurse-patient ratios. And I think also one of the critical things is, and what all the research, and I know your documents refer to the research as well, is being very mindful around the skill mix. So it's never just about numbers, but it's how many qualified nurses that you have. And whilst your structure is quite different to us in Australia, in that we still have a very significant enrolled nurse workforce, for us it's been very critical to make sure that our nurse-patient ratios are made up of registered and enrolled nurses, rather than what governments and what hospital employers want is a cheaper, less qualified workforce, and things are just too busy. Patients are too unwell not to have that expertise in very, very significant numbers. So I wish you all the best, and as I said, I feel very privileged to meet you and try and support you in your campaign, and it'll be great when we see ratios in the UK as well. Thanks.